Okay, so let's look at diastolic function. Just take a second to think about diastolic function. All right, so at the end of systole, so when we say systole, then the LV, let's just look at the left side. At the end of systole, when the LV contracts, push blood across the left ventricular flow tract, across the aortic valve into the aorta. At the end of systole, the aortic valve closes. The mitral valve is still closed. The mitral valve is not yet open. If you remember, that period of time before the mitral valve opens, that's what we call the IVRT, the isovolumic relaxation time or period. So that is the period of time from the aortic valve closing to just when the mitral valve opens. So in IVRT, all the valves are closed. So it is from the aortic valve closing to just when the mitral valve opens, and that's IVRT. And that's a very important part of diastolic function. Okay? So after you have your IVRT, then the mitral valve opens, and then there's an almost suction of blood from the left atrium across the mitral valve into the LV, and we call that your E velocity. You remember that? You tend to get an equalization of pressure between the LV and the left atrium. So equalization of pressure between the LV and the LA, and that period of time you call diastasis. Okay? So with diastasis, you get an equalization of pressure in the LV and the LA, so you essentially get no flow. You'll see that some patients will have a well-defined diastasis, and some patients just don't have it. After the diastasis, then the atrium contracts and push an additional amount of blood, an additional amount of blood from the left atrium across the mitral valve into the LV. And that is what we call you get your so-called A velocity. So if you look at it, when we talk about the diastolic function, so diastolic function starts as soon as the aortic valve closes and you inscribe your IVRT. Then the mitral valve opens and you get suction of blood from the left atrium into the left ventricle, giving rise to your E velocity. You get a rapid equalization of pressure between the LV and the LA, no flow. We call that a diastasis. And then the atrium contracts to give rise to your A velocity. If you look at the heart when the heart contracts, basically what happens, the base moves up towards the apex. And in diastole, when the heart relaxes, the base moves away from the apex. The base moves down. Okay? So if you're going to look at diastolic function, it's important for you to look at the mitral inflow, because the mitral inflow will give you your IVRT, it will give you your E velocity, it will give you your diastasis, and it will give you your A velocity. So the mitral inflow is very important. to look at to assess diastolic function. The mitral annular velocity is also very important because remember what we said. In systole, the base of the heart moves up towards the apex. Okay, and we can look at how much the base of the heart moves up towards the apex, and we can talk about, we talk about a MAPSI, mitral annular systolic plane excursion, if we're looking at systolic function. And in diastole, the base of the heart moves downward, and we talk about two mitral annular velocity, the early velocity and the late velocity. The early mitral annular velocity we call our E prime. The late mitral annular velocity we call our A prime. Okay? If you remember your pulmonary veins, you have four pulmonary veins that enters the left atrium, two on the right, two on the left, two upper and two lower. Okay? Four pulmonary veins. And these pulmonary veins take oxygenated blood from the lungs and drains the blood, the oxygenated blood, into the left atrium. So if you look at ventricular systole, when the ventricle is contracting, the mitral valve is closed and the left atrium is still being filled with blood from the pulmonary veins. In ventricular diastole, when the ventricle is in diastole and the mitral valve opens, blood is still flowing from the pulmonary veins into the left atrium. So you get a systolic component and a diastolic component. However, when the atrium contracts, it pushes the blood into the pulmonary veins in the opposite direction. So if you were to look at your pulmonary vein flow, you'll get a systolic component, a diastolic component, and what we call the atrial flow reversal. Because when the atrium contracts, it's going to push blood in the opposite direction. Okay? So we can use these things to talk about how well the heart is performing its diastolic function. And then if the diastolic function is compromised, we can talk about diastolic dysfunction and we can grade it. Another very important measure when we're talking about diastolic function is the left atrial volume and the left atrial pressure. Because when we talk about diastolic dysfunction usually results from abnormal relaxation of the LV, or if the LV is stiff and it doesn't relaxes properly to fill with blood. So when the heart starts to develop problems with diastole, it usually starts with abnormal relaxation. So the LV doesn't relax properly. And then as that progresses, then the LV becomes stiff. It doesn't fill with blood. So what's going to happen? It's going to the back pressure is going to increase. So you're going to get an increase in the LV filling pressure, the left atrial pressure. And if this increase in pressure continues for any period of time, you're going to get an increase in the left atrial volume. The left atrium is going to get big. Okay? So we can use these parameters to assess if there's a problem with diastolic function. And then if there's a problem with diastolic function, we can grade it in terms of looking at its severity. All right, so I essentially just went over the whole of diastolic function and dysfunction. So diastole is the period of the cardiac cycle when the heart is being filled with blood. So we said that. At the end of systole, when the aortic valve closes, the mitral valve does not open immediately. There is a period of time before the mitral valve opens. And that period of time is what we call the IVRT, isovolumic relaxation time or period. Okay. Um, okay. This is what we call the Wiggers diagram, and let's look at the Wiggers diagram because you should have an idea. Basically, the Wiggers diagram is a series of graphs. The first, of course, is what we call a phonocardiogram. When we talk about phono, it's something you listen to, okay? So when you listen to the heart, you get the first heart sound, okay? You listen. The first heart sound is when you have closure. So you're only going to hear valves when they close. You don't hear valves when they open. So the first heart sound occurs when the mitral valve closes. The second heart sound occurs when the aortic valve closes. So the period of time, so when when the mitral valve closes, that's the end of diastole. And when the aortic valve closes, that's the end of systole. So the period between mitral valve closure and aortic valve closure, that's systole. That's when the heart contracts. Okay? And then the period of time between the aortic valve closing and the mitral valve closing is the diastolic period. Okay? So just think about it. When the aortic valve closes, okay, you're not going to hear the valve, the mitral valve opens, but you have an IVRT. We'll talk about the IVRT. It's a short period of time before the mitral valve opens. The mitral valve opens, then the mitral valve closes. So all of this period is your diastolic period. During the diastolic period, you can hear what we call a third heart sound. You can hear a fourth heart sound, okay? And then the cycle continues. So a phonocardiogram allows you to listen to the heart sounds and you can plot them on a graph, okay? Of course, knowing that systole is between the closure of the mitral valve and the closure of the aortic valve. Diastole is the closure of the aortic valve and closure of the mitral valve, okay? The next one is your electrocardiogram. So the next graph is your electrocardiogram, your ECG or EKG, and all of us have done ECG. You know that systole, every lecture I gave us, a systole is from the onset of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. So you can just align it to the others. The third graph is your ventricular volume, okay? Ventricular volume. So in systole, the volume in the ventricle is going to decrease, and you can see that's depicted here, because when the ventricle contracts, it pumps blood out, so you expect the volume to decrease, okay? In diastole, when the mitral valve opens, then the heart starts filling up with blood again, so the volume is going to increase. So this is your ventricular volume, just showing you that in systole the volume decrease, in diastole the volume increase. Okay, and then the fourth graph is your ventricular pressure. So what happens to the pressure in the ventricle when the ventricle contracts? When the ventricle contracts, the pressure builds up into the ventricle, okay? And it builds up to a peak, and then it falls, okay? That's in systole. So when the ventricle contracts, the pressure builds up. And then in diastole, when the heart relaxes, the pressure falls. Okay? And the same thing with your atrial pressure. The pressures in the atrium, okay, in systole, you get a slight increase, okay? And in diastole, the atrial pressure should be similar to your ventricular pressure in diastole. So the atrial pressure in diastole and the ventricular pressure in diastole should be similar, okay? But in systole, the ventricular pressure goes way up because you have to generate a significant amount of pressure to eject the blood, whereas the atrial pressure is not as high, okay? Then you have your aortic pressure. So the aortic pressure, the systolic pressure in the aorta is similar to the systolic pressure in the LV. The diastolic pressure in the aorta, however, is much higher than the diastolic pressure in the LV. And if you put all of them together, that's what we call the Wiggers diagram. So you need to familiarize yourself with each of these graphs, know what they represent, because they can give you this in the exam and ask you, a number of things about them. So know about the Wiggers diagram. All right. So going back to what we've been saying all night.
Yeah.
So okay, someone is having interference. Please address it. Okay, so going back to what we've been saying all night. At the end of systole, when the aortic valve closes, just before the mitral valve opens, you have your IVRT, which is your isovolumic relaxation time. Okay, it is the period between the aortic valve closing and the mitral valve is still closed. So essentially, all your valves are closed. So it's the period between when the aortic valve closes and the mitral valve is still closed. Okay, then the mitral valve opens, and you have your E velocity, which is the passive early filling of the left ventricle. It is, as we describe it, it's like a suction of blood from the left atrium into the left ventricle, so-called E velocity. Then the diastasis, that's a period between early passive filling and late active filling. That's between E and the A, where you have equalization of the pressures between the left ventricle and left atrium, and you have no flow. Some patients, you'll have a prominent diastasis. Others, you won't have any diastasis. You just go from E to A, okay? And then A is the active late filling of the ventricle due to atrial contraction. So the atrium is contracting now, giving rise to your A velocity. So to get your mitral inflow, if this is your apical four-chamber view, your cursor is right here. Put the sample volume at the tip of the mitral leaflets. Of course, your left ventricle, your left atrium, okay? And when you press your P doubler button, okay, you will see this is flow across the LVOT. Then you get your IVRT, okay? isovolumic relaxation time. Isovolumic because there's no volume change. Okay, there's no change in volume. Okay, so the at the end of ejection across the LVOT, the aortic valve closed. The mitral valve is still closed right there. It hasn't opened yet. So this period of time is your IVRT. Then the mitral valve opens. When the mitral valve opens, there's like a suction of blood from the left atrium across the mitral valve into the left ventricle, giving rise to your E velocity. Then in some patients, you're going to have a diastasis, equalization of pressure between the LV and the LA, no flow. There is no flow because you have equalization of pressure. Then at the end of the diastasis, the atrium contracts. The atrium contracts, and you're going to set up your A velocity. Okay? At the end of your A velocity, the mitral valve closes. The mitral valve closes right here. The aortic valve is not yet open. Okay? This period of time is what you call your IVCT, isovolumic contraction time. Then at the end of your IVCT, the aortic valve opens and then you have flow across the left ventricular flow tract. So these parameters right here tells you about diastolic function. Okay? And so this is what it actually looks like. This is your cursor right there. Sorry, this is your probe. Remember, your probe is right there, or your transducer. It's your two-dimensional echo. The cursor is there, sample volume is right there. You press the PW button and you get these patterns, okay? All right, so E velocity, A velocity, E velocity, A velocity. You see, you can't, there's no prominent diastasis, okay? There's no prominent diastasis, but you can see, you know, your LVOT flow is about right there. In order for you to get a nice LVOT flow and your mitral inflow, you would have to move the cursor a little bit closer to your LVOT, so about mid position. Okay, if you want to just get pure mitral inflow, then it's at the tip of the mitral leaflets, and you get your E velocity, your A velocity. So we measure the peak E. We measure the peak E, that is the velocity. Remember, velocity is on the vertical axis, time is on the horizontal axis. So if you go straight across, you can get your E velocity. Okay? We also measure something called deceleration time, which is from peak E to the baseline. Okay, so the time it takes to go from peak E to the baseline, that's your deceleration time. Okay? In a normal individual, the E should be bigger than the A, like in this scenario. The deceleration time should be less than 250 milliseconds. And when you measure your IVRT, it should be between 60 and 90 milliseconds. Okay? So you have to know how to do these measurements. Again, peak E, that is the E velocity, you just come across to, so all you do when you're doing the study, you put the pointer at the top of the E, and the computer will give you the E velocity. To get your deceleration time is going to be from the peak E to the baseline. This is the time it takes to travel from peak E to the baseline. So it's time. So to give it a deceleration time. Again, the normal deceleration time, usually less than 250 milliseconds. And then the IVRT To get your IVRT, you have to put your sample volume midway between your mitral inflow and your LVOT. So probably someplace right there. And you'll get your nice LVOT flow. And then you measure your IVRT. Another very important point, it's best to zoom. It's best to zoom when you're doing any measurements because the error involved in the measurement will be less. So whenever you're doing any measurements, zoom it, especially when you do your IVRT measurements. Okay, enlarge the image. Okay, again, the deceleration time is the time from maximum E velocity to the baseline. Time it takes from peak E to the baseline. All right, and you're going to measure your E velocity, your A velocity. And also your IVRT. So again, you have to modify your the cursor position, okay? So midway between your LVOT and the mitral inflow, and zoom it, okay? So you'll get your LVOT flow, and then at the end of the LVOT flow to the beginning of your E, that's your IVRT. All right, so as we pointed out before, we can look at the mitral annulus, and the mitral annular movement give us important information in terms of diastolic function and dysfunction. Again, in systole, the base of the heart moves up towards the apex. In diastole, the base of the heart moves away from the apex. Okay? And it's supposed to move at a certain excursion, supposed to move with a certain amount of displacement, that's distance, and it's also supposed to move with a certain amount of velocity. So if the velocity or the displacement is off, then you have problem with your diastolic function. So tissue Doppler, we call it tissue Doppler imaging or mitral annular velocities. It is obtained by placing sample volumes at the medial mitral annulus and the lateral mitral annulus. And you're going to use PW, pulse wave Doppler. Okay, so this is your probe right there. Your probe is right there. Apical four-chamber view. Cursor is across this is your mitral annulus right here. This is your mitral annulus. This is the medial mitral annulus. The lateral mitral annulus is right there. Okay. So we want to look at how fast the mitral annulus is moving. The mitral annulus is supposed to move with a certain amount of speed, going up to the apex and moving away from the apex. So when you press your TDI button, tissue Doppler imaging button, which is a form of pulse wave Doppler, you're going to get a systolic excursion, okay? And because the base of the heart moves upwards, it moves towards the apex in systole. This is your probe or transducer. If the base of the heart moves upwards, it's moving towards the transducer. Hence, you're going to get an upward deflection, a deflection above the baseline, your so-called S prime or your S wave. Okay? Again, it's fair game in tests. This initial upstroke is your IVCT. Okay, so they can put a pointer on it and ask you what it is. So this initial upstroke is your IVCT. This is the S wave. Okay, this is the S wave. In diastole, the base of the heart moves downwards, and you get these two downward deflection. You get an early and a late, early and a late. The early we call your E prime, and the late you call your A prime. If you get a deflection just before that, this is your IVRT. Okay, so the little deflection, so sometimes you get a very tiny little deflection, sometimes it might be a little bit more prominent. This would be your IVRT, and again, this initial is your IVCT. Okay, so with your tissue Doppler imaging, you get your, you can call it S prime, E prime, and A prime. So with your mitral annular velocities, the S prime is your systolic annulus velocity, how fast the annulus is moving upwards. And that usually have a certain amount of velocity. Your E prime, this is your diastolic, this is the early diastolic annular velocity. The normal E prime should be above 7 centimeters per second. And this is your A prime, which is the late annulus velocity. A very important point that you should understand, E prime reflects relaxation of the myocardium. So the E prime is giving you information about the relaxation of the myocardium. And the E prime is reduced if the patient have any type of heart muscle disease, the E prime is reduced. The E prime is reduced if the patient have any type of heart muscle disease. Okay? Very important point. E prime is reduced if there's any heart muscle disease. Okay? So if the patient have any problem with myocardial relaxation, your E prime is going to be reduced. So decreasing E prime is one of the earliest markers of diastolic dysfunction. So if the patient comes to you with any type of muscle disease, E prime is going to be reduced. And these things have changed a little bit, but in essence, they are just, they still tell you what's going on. If you look at your medial E prime ratio, so remember the mitral inflow, you're going to measure the E velocity, and then with your mitral annular velocity, you measure your E prime velocity. If you do the ratio of E to E prime, if it's greater than 15 at the medial annulus, then it suggests that your left atrial pressure is elevated. It suggests that you have elevation in the left atrial pressure. If the E prime at the medial annulus is greater than or equal to 15, it suggests you have elevated pressures. The heart is efficient when the pressures are low inside. Okay, once the pressures inside the heart becomes elevated, then the patient is developing heart failure. Okay, you want to see your EE prime less than 8. Okay, that usually correlates with good function. Now, pulmonary vein flow. Remember what we said. Okay, your two-dimensional echo is on top. This is your probe or your transducer, and your pulmonary veins. You have one here and another here. This is your right superior, and then the left superior will be over here. So remember, you have 4 pulmonary veins that drains into the left atrium. So you just need to identify one. The sample volume is right there. You press. So again, this is a P doubler measurement. You press your P doubler, ECG is on top, and you get a systolic component, diastolic component, and you get an atrial flow reversal. Remember what we said in systole, blood is flowing from the pulmonary veins into the left atrium. In diastole, blood is flowing from the pulmonary veins into the left atrium. But when the left atrium contracts, it's going to force blood in the opposite direction. So that is why it's going to push blood away. So the blood is going to be moving away from the transducer. Remember, the pulmonary blood flow, the pulmonary vein flow is going into the atrium. It's moving towards the transducer. That is why you get your velocities or your envelopes above the baseline, systolic component, diastolic component. Your atrial flow reversal is going to be below the baseline because the blood is going to be pushed away. It's going to push, when the atrium contracts, going to push the blood in this direction, which is away from the probe. Okay, so it's going to be below the baseline. So this is your normal pulmonary vein flow, where the systolic component is a little bit bigger than your diastolic component. Okay, very important when you're analyzing diastolic function or dysfunction, because as you develop diastolic function or dysfunction, this systolic component becomes smaller or less. Okay, so again, you have a systolic with your pulmonary vein velocities. You have a systolic wave, S, diastolic wave, and the atrial flow reversal. Okay, as the left atrial pressure increases, or as you develop diastolic dysfunction, then the systolic component becomes less and less. All right. The other thing we're gonna mention before we end this the lecture is that, again, the left atrial volume gets larger once the left atrial pressure starts to go up. The left atrial volume gets larger, and the number you need to remember is 34 mLs per meter squared. Okay, that's the left atrial volume index, 34 mLs per meter squared. So if you want to assess diastolic function, you have to look at your mitral inflow. You have to look at your mitral annular velocities. You have to look at your pulmonary vein flows. You have to look at your EE prime ratio. And you have to look at your tricuspid regurgitation velocity, TR velocity. So those are the things that you need to look at, and you need to know how to assess them. Because our next session, we're going to talk about how do you grade diastolic dysfunction. Okay, so we look at normal diastolic function, and then the next session on Thursday, we'll talk about how you're going to assess